morning. I almost feel so warm and friendly to everybody. Welcome to Aspen. What an incredible morning and wonderful way to start our day to put on our fresh ideas. I'm Adrienne White-Gaines. I'm the CEO of the American Osteopathic Association. And I want to provide a little bit of context as to why the American Osteopathic Association has co-sponsored this particular panel discussion with our partners, the American Hospital Association. Many people are familiar with the fact that osteopathic physicians are now moving towards 20% of the physicians in this country practicing in every specialty, but their unique training and education gives them, from the day that they begin in their osteopathic medical schools, a patient-centered focus, a focus on mind, body, and spirit, an understanding that wellness is not an issue of illness or the absence of pain. Wellness is a concept of the whole mind, body, spirit, and wellness and prevention moving forward throughout someone's entire lifetime. And it is for these reasons, then, that we are joining with the American Hospital Association to talk about envisioning a new world that is not about health care, but healthy communities. And so we know that we'll have a vibrant discussion today. We have two osteopathic physicians and a healthcare executive who are going to give you some perspective on envisioning this new world. And we're also going to start with our moderator, Sharon Cake, who is here from the NBC channel in Florida, WPTV, which is an affiliate of the West Palm Beach, Florida station. But we also are so proud that she is the spouse of a pulmonologist, DO, a pulmonary physician, Joe Gyro, who is also a very active leader within the osteopathic physician community and the AOA. So if you will, help me to welcome Sharon Cake.
My husband actually is on the way. He had to tag team kid duty, so he's getting over here and see him come in with the guys in just a couple of minutes. But I think that's my more prestigious title, my spouse of Joe Django. I have been with the NBC affiliate in West Palm for some 21 years now, and married to Joe for 12. And I really wish I had known him. I was sharing with you right before we started, and thank you for the honor, by the way, of asking me to moderate. I really enjoy these dialogues and conversations. But I was sharing with you that I wish I had known Joe at the early stages of my career. I was a consumer advocate reporter right out of the gate, and I had no idea about the world of medicine beyond my annual check with my doc, you know? So I'm covering these issues at least once a week, sometimes twice a week, with no real knowledge of what it takes in the world of medicine to do what you do. And so, not that it would have changed the outcomes of my stories necessarily, but certainly a broader understanding. And I got that indoctrination with 2 a.m. phone calls and 3:30 lab results, and 4:30 he's out the door, and I'm not home for dinner by 8. So thank you for what you do. We like to say at the AOA, doctors that do, and these folks certainly do a lot. It's my honor to introduce involved in the training of medical physician assistants and podiatric students in Arizona since 1997. Please welcome Dr. Jeffrey Morgan. Joe Wilkins is the board chair of St. Joseph Hoag Health in Irvine, California. He has more than 30 years of experience in healthcare, so he's seen a lot and he's done a lot. Joe Wilkins has developed biomedical services for Kennedy Health Systems in New Jersey as well, and is currently a member of the executive team at Quest Diagnostics. Please welcome Joe Wilkins. And Jay Bott, DO. Dr. Bott is the Chief Medical Officer of the American Hospital Association and the President of the Health Research and Educational Trust. Dr. Bott speaks to the quality improvement efforts being undertaken at hospitals across the country, interventions and evidence-based strategies to improve care for patients, and overseeing a national effort to improve equity of care and eliminate disparities. We are very proud of Dr. Bott and all he does. Please welcome Dr. Bott. So let's get right to this and begin by framing the issue from each of your perspectives. What is it that you believe must be addressed to really move communities from health care to health, which is the mantra for osteopathic medicine? What is it that we need to do to move from health care in our communities to health? Let's start with you.
Thank you, Jen. And I also want to thank the AOA for the opportunity to be present and participate in this discussion. I think in a nutshell, what I would respond to that with is that it's going to involve teaching tomorrow's physicians about the idea of moving from patient care to population health, community-based care, and the impact that the community has on the individual's health. In that regard, at ATSU SOMA, we embed our students in community health centers beginning in their second year of medical education. They stay there for their second, third, and fourth years. And they are delivered their didactic education through video casting and podcasting in their second year. And their third and fourth years are traditional, like many other medical schools, rotating in communities. But prior to getting to the community health centers that they'll go to in groups of about 10, they do a needs assessment of the community, health-related needs assessment of the community. And in their second year, when they're embedded in the community, seeing patients in the clinics in their second year, they develop a plan to meet those needs, to implement a research project or of some sort to address that need of the community and the impact that it'll have on individuals there. Now, for those that aren't familiar with community health centers, federally qualified health centers, they represent there are about 3,000, just over 3,000 federally qualified health centers at over 13,000 points of access around the United States that provide healthcare services to some 25 to 28 million people, regardless of their ability to pay. And so they're seeing the sicker, the poorer, and the higher risk individuals. And they do that in the context of an interdisciplinary environment. They have social services, dental services, primary care to include family medicine, internal medicine, OBGYN, pediatrics. It's a comprehensive approach to patient care. So back to my point, I think it's about educating tomorrow's physicians to think more about population health, the impact the community has on the individual.
And so let's get to the community now with you, Joe, because on the front lines out there doing it, we're talking about students here or student doctors. Let's go to you now.
Yes, thank you for that question. From healthcare to health, so that's the question. And I want to answer that from my background, from a lens of my background in terms of how I see the issues around this problem. I have moved from Quest Diagnostics to now a Chief Transformation Officer at Atlantic Health System. My key role and responsibility is to ensure that we transform our healthcare system to be sustainable, to take care of all in our community. And so that's the work we're doing through innovation and just through drive and functional transformation. So that's important. But I grew up in Philadelphia, which is a big osteopathic community.
Poor Eagles fan.
No, this is the year though. This is the year.
Oh yeah, you say that every year.
This is the year. So, but I grew up in a very vulnerable community. I did. I grew up in North Philadelphia, a tough community, and so I saw experiences that I think are important in this conversation. So today, though, when I look at the question, to me it goes back to the key question is healthcare a basic right for American citizens? That's the question to me. And until we answer that question, I think we're going to always struggle. If we were to answer that question to the affirmative that it is, we would be much, much more proactive in how we treat healthcare. We would be more focused around health promotion. I think you would see more collaboration between public health officials, hospitals, physicians, and patients to really move the needle. But as it is, healthcare is a big, big business. And I applaud us for being here today because I think this is an example of collaboration between many different organizations and partnerships that need to be exhibited in the future. And so to me, it's key that we recognize that core question needs to be answered so we can get into the mode of really being proactive about getting to the care needs prior to major issues with people's health. And so it's going to require a major change of thinking myself.
So answering that basic question for you is how to,
yes.
Dr. Bob.
So thank you. I really want to just appreciate the opportunity and this partnership with the American Hospital Association, the American Osteopathic Association, to really spark conversation and action around the notion of healthy communities. And I would agree with Joe in the sense that that is a critical question, that if we're going to move to health, we really have to think about a mindset shift and think differently about delivery and payment so that it supports that movement. Now we know that nearly 90% of the factors contributing to premature mortality relate not to care delivery, but to behavior, genetics, environment. And in order to address those, we have to be thinking upstream and in communities. When we've seen hospitals and care teams think upstream and try to get into prevention and help folks go back to better communities rather than the communities that they may have come from that were plagued by poverty, socioeconomic conditions, poor environmental conditions, unsafe environments, then there's opportunity. And as a primary care doc in a community on the northwest side of Chicago, we've seen that when we've looked at where people live and moved them from poor housing to better housing, that they actually, their headaches or their allergies go away, and then they're not getting imaging or taking time off of work or having to put their kids in daycare that's expensive while they try to get the care they need. And sometimes they can't even access that. I have patients that take 3 buses to get to see me, which speaks to the transportation deserts as well as the food deserts that exist. So I think that we're really encouraged by the work of our healthcare systems and our members across the country who are seeing that this is important in investing in communities and seeing real difference.
Very quickly, a follow-up for each of you. If we could just run down the line and get to the next question. How close are we answering? Close to it that we are answering that question. Mr. Wilkins, let's start with you.
Yeah, I think it depends on where you live.
Yeah.
I mean, I happen to live in both California and in New Jersey right now, and there's a big difference in thinking in California.
Right.
Jeff and I talked about how advanced our community clinics are throughout the communities in California, and the commitment from the government to take care of all is pretty clear. So you see a reduction in the cost of care in California and high quality and access that's significant in California. Where, in the East, where quite honestly the majority of our population is struggling around healthcare access, struggling around quality of healthcare, and struggling around just the whole concept of being proactive from a population health perspective. So it's one of the reasons why I took on the challenge to move from the West to the East to try to help out and bring some of the principles that we've learned through really solid social determinants of health combined with healthcare providers working together will make a huge difference.
Dr. Bud, how close are we to answering the question, in your opinion?
I think we are making great strides towards answering the question. I think it's still a difficult question to answer in terms of the how long it might take, but I know that we're moving in the right direction. The American Hospital Association's board has identified a committee on health strategy and innovation, of which Joe Wilkins is a member, and that committee has really, I think, been thinking about this question of how do we advance towards health and the issue of affordability, and because that is a critical issue for Americans around the country, and what role do hospital and health systems have on that issue. But I think there are just really encouraging examples of how hospitals and health systems are investing in communities.
But all agreement that wellness is the key component, which is one of the messaging that you hear from the AOL all the time in Adrian's opening remarks, is wellness is that kind of cornerstone to get there. All right, let's move on to the next question, if you don't mind. There are more Americans than ever right now with health care coverage. How is this, in your opinion, changing community health care? Beginning with you.
Access to health coverage necessarily means the potential for increased numbers of people presenting to physicians' offices for care, typically for care that's gone unattended to or unaddressed for a number of years. And so initially you're going to see a higher cost associated with addressing this new access to care. Compounding that is the fact that we have a physician shortage in the United States, and so you may have bottlenecks. We have underrepresentation of primary care physicians, typically the physicians that are going to be the first line of defense for those individuals who now have access to care. We have more specialists who we might see coming back to their primary care roots. All of us as physicians, whether primary care or specialty trained, are trained in medicine and in the delivery And it may challenge those specialists to come back to some of the skills that they learned early on.
That's right.
You know, I would be remiss not to say, hey, you know what, this is at risk now, so access clearly has made a difference. We went from an uninsured rate of something like 18 and 19% to now 11. That's 20 to 30 million people that now have at least access to coverage. In most cases, for the very first time, we're actually seeing a primary care physician. So we learned early on in that process, there was a lot of education to this new population that entered into our healthcare system. So that now that's done, we should actually start seeing the results of that in terms of reduced cost, improved quality and lives and outcomes. However, again, that's all at risk right now. So you got to wonder, you know, what are we doing? I think to your other question, I think we can go backwards. We'll have 50 shades throughout the nation in terms of what we're doing, which is really disconcerting to me. But I would say there's been significant benefit around, you know, you don't hear about stories of people coming in late stage cancer at the last minute because they didn't have care, and now, you know, there's nothing you can do for them. You don't hear about people going bankrupt because of the cost of health care. I mean, literally bankrupt because they got a bill that was just way out of line. You don't hear about, you know, the whole issue of, you know, those conditions, pre-existing condition issues. So there's just a lot that we have advanced so far, and we just offer to go, you know, in a different direction.
Dr. Potter, you seeing the same?
Yeah, I would agree. I think what we've got to fight hard to do is not be in a position where we reverse the gains that we've made over the last number of years with getting folks on coverage. And I've had patients that have had chronic disease that because of coverage, they're actually able to think about health, to be able to make decisions proactively about their health that otherwise could and might delay their care so that they end up with kidney failure or other conditions that put their lives at risk, which then they can't work and they can't support their families. It's economic mobility is at risk for these communities. So I think we've got to ensure that we continue supporting Medicaid coverage and other access to coverage so that we are able to move towards health. And it gives hospitals and health systems an ability to think about care delivery differently with folks that are now covered, that are coming to their organization.
So the newly insured population, from what you've seen, all three of you, are coming in more educated, more interested in their health right out of the gate. Is that true for you? In your setting?
I'm not in
Right.
a delivery of care
Right,
setting.
right.
Yeah, it is. I mean, so, you know, our providers would say, hey, you know what, we have seen, you know, patients for the first time, and we really had to, you know, educate them on how to use the healthcare system. And so that investment is now behind us. And so now we're in a routine process where we're seeing those patients on an annual visit, and we're ahead of the big problems that they have. And so it's a big investment. And often, you know, it's a long-term process to see the actual gains from that, but we're well on our way to seeing significant increases in population health.
So next question, this plays right into it. Does access to care automatically translate into improved health? That takes it to the next level, and that is the new question. And if not, what are the barriers? There's certainly plenty of them. Dr. Morgan, let's start with you from your perspective.
I think the simple answer is no. It doesn't equate to improved health care. You know, there are the number of barriers that exist for people with or without insurance include food insecurity. We talked about that earlier. Homelessness, you know, not having access, transportation access, etc. All of these things impact an individual regardless of their access to health care. If they have insurance but can't get to the physician's office, if they're given a prescription in the office but can't afford the copay for it, etc. Because food was more important that day, it matters.
7 years ago, we weren't even thinking about managing the health of a population or community. We were just fee for service. So today, there's much broader, higher level thinking about how to be proactive through our communities. We have a number of programs under Medicaid that helps us really develop this ACO model, accountable care model, that really has improved both quality and costs in different new models of care. I would say this thinking has led to significant collaborations and partnerships within the community. And so one example local public health officer in Orange County, California, asked the question, you know, what can we do to reduce hunger in the county? And he asked this question of the food bank executive. He said, if we just redistributed food, the waste, he may be able to do something. So we actually started this program called Waste Not OC, Waste Not Orange County, created a website, developed a number of partners, including hospitals, you know, physician community, even taxi cab drivers to help distribute the food around, pantries. And so now we have a way of screening for food insecurities in our providers' offices. When providers get an affirmative, now they have a solution online. They can direct that patient to a pantry. They actually have a little pantry kit in their office as well. And so that's really innovative thinking in terms of thinking, you know, forward thinking around solving a problem together collaboratively. So food is really medicine, if we really think about it. If we can provide nutritional food, that's one key factor of the social determinants of health that we have to solve together.
So I'd say that you know, there is increasing conversation about coverage to care, but right now we certainly have focus on protecting coverage. I would say that what it's allowed us to do, to Joe's point, is really think about unique partnerships. And one of them, I'll share an example of, is really two competing hospitals in Charlotte in a market that fierce competitors for many years, where their chief executive officers actually came together and said, we want to address a problem of poor health in our communities. So identified and looked at the 12 social determinants of health, worked with their community health department, with the local university, with community members, and Carl Amato and Gene Woods, who's the the CEO of Carolina's healthcare system, the HA board chair, got together and said, we have patients coming to both of our emergency rooms, and they're shuttling back and forth. We don't know where they're coming from and why. How do we address that problem in appropriate use and help think upstream? And so I identified 6 zip codes where the data showed a majority of those patients coming from, and together invested in primary care access for that community. Because of the community plagued by food insecurity, transportation, by poverty, by lack of jobs, and they're seeing real benefit from them. I know Jesse Kierden from Novant is in the audience, who's really been an active player in that collaboration. But it's really those kinds of unique, non-traditional partnerships that are really making a difference in the health of communities.
And that's creating access to care.
If I could, Jen, just to follow up on that, just to put that into real dollar figures, those types of actions, as they've played out in community health centers across the United States, have saved the American taxpayer something around $28 billion in the 2013-14 estimates, and infused the communities that they provided that care in with another $20 billion in economic stimulation.
I want to get back to these programs because we have a specific, but I'm interested and curious, I'm sure everybody else is, where are we in terms of sharing your knowledge with other communities across the country? Those numbers are significant because that's how I was wondering how you were, you know, charting it and keeping track of the numbers and what it means to the public. Primary care is often referred to as the front line of medicine. Help us understand the role of primary care physicians. It's always changing, it seems, isn't it? Physicians in improving community health. What is the role of primary care physicians in improving community health? You've all touched on this just a bit, but let's talk about, let's change that a little bit and begin with you and come down this way.
So I think that primary care continues to have an important role, and an increasingly important role as health moves outside the 4 walls of a hospital, and that the system is a continuum in communities and with acute and chronic care. But the other piece that's going to be important to them is how they work differently with the different parts of the workforce, because traditionally physicians have been trained to focus individually and with their panel of patients, but they've got to think about broader issues, ask different questions, and work effectively with the care team that's evolving as well around them, from advanced practitioners to community health workers to patients who are taking increasing responsibility for shared decision making with their families as well.
Yeah, I would say that unfortunately we reward our specialists more than our primary care physicians, which is quite disconcerting around, the incentives. When you look at students, medical students, they often want to pursue the specialties because that's where the money is. And so I think we got to really address that issue because we are not going to be successful as a nation if we don't have, the right number and quality of PCPs or primary care physicians. We need to have primary care physicians throughout all of our communities. And we struggle. We struggle in rural communities. We struggle in urban communities. PCP or primary care physicians are critical to establishing that relationship with the individual and then directing the care appropriately in a coordinated manner. And so every model of success has at the center of that the primary care physician, every model. And so I think that we need to acknowledge that. We need to reward primary care physicians, incentivize them more. And I think that if we do that, I think that'll make a big difference. So it's crucial.
And to your point earlier about the ACOs, that's why that concept is catching on and doing so very well in a lot of communities. Dr. Morgan.
Yeah, well, for the record, primary care includes family medicine, internal medicine, OBGYN, pediatrics. But there are additional needed specialties in these communities of need that include general surgery, psychiatry, and emergency medicine physicians. And so when you lump them all together, they really do now comprise what I think would be considered a primary care approach. And the communication, collaboration, remuneration, Jay and Joe hit them all.
Absolutely. Next question is for the docs on the panel here. What is a DO? In 2 words or less. No.
Value added.
I wouldn't do that to you. We can't even.
2 words or less. Value added.
So you did it.
Yes, I think to put that into context, America knows about physicians. They typically think about MDs. We see advertisements that MD, the letters are associated with a physician, but there are 2 types of physicians licensed to practice medicine and surgery in the United States, an MD and a DO, an allopathic and an osteopathic physician. They're all trained in very similar manners in the basic sciences, the disease management, etc. The difference being that physicians in their training are educated in 2 different realms. They're educated about a philosophy of care, whole person health care, and they're educated to use manual diagnostics and treatments, so diagnosing disease with their hands and affecting change with their hands to allow the body to heal itself. It's value-added medicine.
Love that. Dr. Bob.
Yeah, I would say that osteopathic physicians have a holistic view of the patient and their health. I ask about individuals and their families that I got from where they live to what matters to them and their preferences and what's going on in their lives. But if it had not been for my osteopathic training, in fact, my own physician who was an osteopathic doc, who went and took care of me when I had low back pain, the first question he asked me in the office visit was, tell me a little bit about what's going on with you day to day and what's happening in your life. That really sparked my interest in osteopathic medicine because then I started shadowing him and felt that and saw that the kinds of questions and interactions they had with patients was different than I had ever experienced before.
And I've heard you all say at some point in our chat, we have 5 minutes to get through a couple questions, so not too much time, but wellness was the cornerstone. Did you feel like that was in your training?
Sure.
That's
Yes.
in your training, right? It's the cornerstone of what you do. All right, next question. Help us understand how effective, that you both talked about this, so if you have a deeper dive on this, we'll do it quickly, but you really gave us a good glimpse into this a few moments ago about partnerships. Help us understand how effective partnerships are achieving your organizational goals. Why are they important? Is there another one you can share with us, Dr. Bott? I know you're doing this all the time.
Yeah, I think one of the issues that we struggle with is around diversity and inclusion and reducing health disparities. How do we get to health equity? And that really, I think, is anchored around enhancing diversity and inclusion in governance and leadership of organizations and in communities, reducing disparities and strengthening community partnerships. And recently, the American Hospital Association launched a partnership with the National Urban League, the nation's largest civic rights organization with the nation's most influential hospital health system organization to address three things. One was connect hospital and health system CEOs to National Urban League leaders in their communities to advance diversity and inclusion on their governance and leadership. Two, to help hospitals and health systems and their communities understand the impact of community health workers and how do you embed them onto care teams to really make a difference towards that movement of reimagining healthcare to health. Three is to have voice and input into urban policy solutions. Most recently, the National Urban League came out with a report on healthcare in America for African Americans, and the Hospital Association had a voice into that conversation. And so I think that those kinds of, again, I think non-traditional groundbreaking partnerships are really going to help move the needle on these issues.
Mr. Wilkins, quickly.
Yeah, absolutely. So, I think consumers see us as health systems always sort of competing out there in terms of the advertisement, we're better at cardiac care, but you're starting to see that switch to what we call now co-opetition. So cooperating together to do a better job. And within our system, Atlantic Health System, we have a collaborative called All Spires. We inspire us all to be great. And so we have the two largest systems in New Jersey, us and Meridian, Hackensack together, along with three other major systems in Pennsylvania. We meet every week and discuss opportunities to work together and collaborate. And we've seen tremendous success over the last 3 years just through that. So I do think you're seeing a shift towards this cooperation to help really make sure we improve the health of all people in all communities.
It's great to see as a consumer. It's very confusing. Dr.
Yes.
Morgan, anything on this?
For ATSU Soma, the relationship we have with community health centers across the United States is critical. We embed our students in only 12 of those 1,300 plus community health centers, or FQHCs, around the United States. But embedding students in that contextual learning environment has been so successful. We have about an 86% retention rate of our graduates staying in primary care and those additional needed specialties that I mentioned.
Fantastic. More organizations, or many organizations, are focusing on patient activation as the key to improving outcomes and lowering costs. Is this concept part of your strategy? And if so, how can it be achieved? Dr. Morgan?
Patient activation, I'm going to say patient engagement. And I think patient engagement is critical. It always has been. I don't think it's a new focus. I like that there's a new spotlight on it, but involving patients, patient-centered healthcare is critical.
You remember the days, and there may be still existing in some communities, where when you asked your doctor for your medical records, you got some resistance, that you just couldn't even stay on track of your own information that really belongs to you. But that's, I think, going by the wayside. And so we're starting to connect with patients through their own medical record in their application, on their phone, or whatever means they need. So I think having their own information in their hand is going to help activate their ownership of their own
That
healthcare.
is fascinating, covering that. Yes, Dr. Bott.
So I think that I would agree with Jeffrey and Joe about how we're thinking about this, and I think that we're seeing patients and their families play a more active role in healthcare and in their own health and changing behaviors. And thinking that we all still have those that need some further partnership and assistance. There's still a long way to go. So there's a continuum. And I think the question is, how do we make the healthy choice the easy choice for our patients and their families? And I think keeping them at the center and focusing on that question as we design care delivery and the things we do, both from in the hospital and health system to the community, I think is going to be critical.
Quick closing comments as we wrap up before we move on to questions from everyone. Any thoughts that you had that you'd love to share before we wrap up?
The only thing I have is a sense that, in this day and age that we live in today, we really need to figure out how we increase our engagement and advocacy from physicians, hospitals and health systems, public health, the people that actually do the work, that actually provide the care, to help design the solutions for the future. I think is key for, again, the people that actually do the work. Health plans and pharma, it's about the people that actually do the work that's going to be, at the end of the day, it's going to help us solve it.
Which is why it's so important that we have this, where the people who are doing are talking and at the table. Dr. Bott, to you on that, wrapping up.
I would say that it's going to take thinking critically and outside the box and bringing unique voices and different perspectives together to actually hear what the challenges are we're seeing frontlines and really activating them. When I was working at the intersection of public health and healthcare delivery in the city of Chicago, we gave opportunity for residents to chime in about potential infectional foodborne exposure that they might have had through social media. So when we say who's the public health workforce of the 21st century and beyond, it's really going to be the resident, the patient, and their family. And I think honoring the commitments that we have in the Advancing Health in America framework that the American Hospital Association has launched earlier this year is going to be critical. And I know our Executive Vice President, Mary Jane Worth, will share in that in her closing, that framework is going to be critical to moving forward.
Dr. Morgan, final thoughts.
The community, the communities that we serve and the public health that influences those communities, the delivery of care within those communities all, again, intersect in something called the community-oriented primary care. And I think a renewed interest and focus on community-oriented primary care, or COPC medicine, I think has value.
Thank you to all of you for what you do. I will tell you unequivocally, the American public does not know how hard you work. They don't know about the 2 a.m. phone calls and the 3 a.m. lab